Ovarian torsion, understanding emergency gynecological conditions. Ovarian torsion occurs when an ovary twists abnormally, compromising its blood supply. This surgical emergency requires prompt recognition and treatment to prevent lasting reproductive damage. What is ovarian torsion? Ovarian torsion, also known as adnexal torsion, represents a serious gynecological condition in which an ovary becomes twisted around its ligamentous attachments and supporting structures. This abnormal rotation results in progressive compromise of the blood supply to the ovary and surrounding tissues. The condition can occur unilaterally, affecting only one ovary, though bilateral cases are rare. The severity of the condition depends on the degree of rotation and duration of compromised perfusion, which can range from partial twisting to complete rotation of multiple turns. Understanding this condition is essential for both healthcare providers and patients, as early recognition dramatically improves outcomes and preserves reproductive function. Anatomical basis and risk factors. The ovary maintains its position within the pelvis through several ligamentous structures, including the ovarian ligament medially and the infundibulopelvic ligament laterally. These structures provide some mobility, which paradoxically can predispose the ovary to torsion. Several anatomical and physiological factors increase the likelihood of this complication. Ovarian enlargement, whether from cystic formations, tumors, or stimulation during fertility treatments, shifts the ovary's center of gravity and makes rotation more probable. Pregnancy itself increases risk due to the hormonal milieu and anatomical changes within the pelvis. Sudden movements, rapid positional changes, or even sexual intercourse have been documented as precipitating factors in some cases. Key points: ovarian cysts or functional enlargement from hormonal changes. Ovarian neoplasms, including both benign and malignant tumors. Polycystic ovary syndrome with enlarged ovaries. Fertility treatment with ovarian hyperstimulation. Pathophysiology and vascular compromise. The pathophysiological cascade of ovarian torsion involves progressive vascular obstruction with distinct temporal stages. Initially, the twisted pedicle compresses venous outflow, leading to congestion and edema of the ovarian tissue. As venous pressure increases, capillary perfusion diminishes even though arterial inflow may initially continue. This creates an ischemic state where tissue demand for oxygen exceeds supply. Without intervention, continued twisting eventually compromises arterial flow as well, creating complete ischemia. The duration of ischemia is critical. Tissues can tolerate several hours of compromised perfusion before irreversible necrosis begins. If torsion remains uncorrected beyond approximately 8 to 12 hours, permanent tissue damage and loss of ovarian function become likely. The inflammatory response triggered by ischemia reperfusion injury further complicates the tissue damage even after successful detorsion. Clinical presentation and symptoms. The clinical presentation of ovarian torsion varies considerably among patients, making diagnosis challenging. While the textbook presentation involves sudden onset severe unilateral pelvic pain, the actual clinical picture can be more nuanced. Many patients report pain that develops more gradually or waxes and wanes over hours. The pain is typically localized to the lower abdomen or lower back on the affected side, though it may radiate more broadly throughout the pelvis. Associated gastrointestinal symptoms frequently accompany the pain, contributing to diagnostic confusion with appendicitis or other abdominal emergencies. The severity of pain correlates somewhat with the degree of vascular compromise but not always reliably, as some patients with complete torsion report moderate discomfort while others with partial torsion experience severe pain. Key points: acute or insidious onset unilateral lower abdominal pain. Nausea and vomiting, sometimes severe. Low-grade fever in some cases from tissue inflammation. Tachycardia and hemodynamic changes in severe cases. Diagnostic approach and imaging. Diagnosis of ovarian torsion relies primarily on imaging, as clinical presentation alone lacks sufficient specificity. Transvaginal ultrasound represents the initial imaging modality of choice due to its excellent resolution of pelvic structures and lack of radiation exposure. The ultrasound appearance includes characteristic findings of an enlarged ovary with multiple peripheral follicles and abnormal Doppler flow patterns. However, Doppler ultrasound must be interpreted cautiously, as presence of flow does not exclude partial torsion or early-stage complete torsion. Color Doppler may demonstrate reduced or absent blood flow, particularly in the central portions of the ovary, suggesting compromised perfusion. When ultrasound findings are inconclusive or when additional information about surrounding structures is needed, computed tomography provides broader anatomical detail and can identify complications such as hemorrhage or necrosis. Magnetic resonance imaging, while not typically first line, can be valuable in selected cases for tissue characterization and treatment planning. Differential diagnosis considerations. The diagnostic challenge of ovarian torsion lies partly in its mimicry of other acute pelvic and abdominal conditions. Appendicitis remains a common initial diagnostic consideration, particularly in patients with right-sided pain and associated gastrointestinal symptoms. Acute diverticulitis, pyelonephritis, and renal colic can present with similar pain patterns depending on location. Gynecological conditions such as ruptured ovarian cysts, acute pelvic inflammatory disease, and ectopic pregnancy must also be considered in reproductive-aged women. Bowel obstruction can produce comparable symptoms when gas-filled loops are involved. The presence of elevated inflammatory markers and fever favors infectious etiologies like appendicitis or pelvic inflammatory disease, though some degree of elevation occurs from tissue ischemia in torsion. Careful history-taking regarding pain onset, associated symptoms, and menstrual history combined with imaging findings helps narrow the differential diagnosis. Complications and tissue damage. Prolonged ovarian torsion leads to several serious complications that affect not only immediate management but also long-term reproductive outcomes. Necrosis of ovarian tissue represents the most direct consequence of sustained ischemia, resulting in permanent loss of that ovary's function if detorsion occurs too late. Secondary bacterial infection can develop within necrotic tissue, potentially progressing to sepsis if the affected ovary is not removed promptly. Hemorrhage into the ovary and surrounding tissue occurs when the vascular compromises leads to bleeding from disrupted vessels. Thrombus formation within ovarian and pedicle vessels perpetuates the ischemic insult even after mechanical detorsion. Perhaps most concerning for reproductive-aged women is the potential for permanent infertility resulting from loss of one or both ovaries, particularly if bilateral torsion occurs or if previous torsion resulted in removal of an ovary. The degree of fertility impact depends on whether the affected ovary can be preserved and its functional status following detorsion. Emergency management and surgical treatment. Once ovarian torsion is suspected, urgent surgical evaluation and typically operative intervention become necessary. The standard surgical approach involves laparoscopic exploration, which offers the advantages of minimal tissue trauma, rapid diagnosis confirmation, and ability to perform definitive treatment through the same minimally invasive access. Upon visualization, the surgeon assesses the extent of tissue viability by observing color changes, tissue turgor, and degree of swelling. The primary surgical goal involves detorsion, carefully unwinding the twisted pedicle to restore normal orientation and allow reperfusion of the ovary. In many cases, particularly when caught early with viable tissue, detorsion alone suffices without removal of the ovary. However, when tissue is clearly necrotic with no chance of recovery or when hemorrhage is extensive and uncontrollable, oophorectomy, surgical removal of the ovary, becomes necessary. The decision to preserve versus remove an affected ovary requires clinical judgment balancing potential recovery of function against risks of ongoing ischemia and infection. Prognosis and long-term outcomes. The prognosis of ovarian torsion depends critically on the interval between symptom onset and treatment. When detorsion occurs within 8 to 12 hours of symptom initiation, ovarian tissue typically remains viable and preservable, with restoration of function often occurring within weeks to months. Delays beyond this window substantially increase the risk of permanent tissue damage. Even when ovarian tissue appears necrotic at the time of surgery, some degree of recovery has been documented in isolated cases, though the outlook is generally poor. Fertility outcomes following successful detorsion and ovarian preservation are generally favorable, with many women retaining normal reproductive function. Studies indicate that preservation of even a portion of ovarian tissue can maintain hormonal function and potentially preserve some fertility. Recurrence of torsion in the contralateral ovary or the same ovary occurs in approximately 5 to 15% of cases, with slightly higher recurrence rates in women under age 30. Some surgeons advocate for prophylactic ovarian fixation, oophoropexy, during the initial surgery to reduce recurrence risk, though this remains somewhat controversial. Prevention and patient counseling. While ovarian torsion cannot always be prevented, certain measures may reduce risk in susceptible individuals. Women undergoing fertility treatments should be counseled about the increased torsion risk, particularly with ovarian hyperstimulation syndrome. Those with known ovarian cysts or masses should understand the importance of monitoring and prompt reporting of acute pelvic pain. Rapid positional changes should be undertaken cautiously in women with enlarged ovaries. Young women with a history of one episode of torsion require counseling about recurrence risk and the importance of seeking immediate care for severe acute pelvic pain. Sexual education regarding gentleness during intercourse may be relevant in some cases, particularly for women with enlarged ovaries. Regular follow-up imaging of known cysts helps identify those enlarging significantly enough to warrant intervention before torsion risk escalates. Women who have undergone oophorectomy due to torsion should receive counseling about their remaining ovaries' function and fertility implications. Conclusion. Ovarian torsion represents a gynecological emergency requiring rapid recognition and intervention to preserve reproductive function. The condition's variable presentation can complicate early diagnosis, necessitating a high index of suspicion in any reproductive-aged woman presenting with acute pelvic pain. Advanced imaging, particularly transvaginal ultrasound, provides essential diagnostic information that guides urgent surgical evaluation. Surgical detorsion, when performed promptly before tissue necrosis occurs, offers excellent outcomes with preservation of ovarian function in most cases. Healthcare providers must maintain awareness of this condition and its risk factors to minimize diagnostic delays. Women who experience episodes of torsion or carry risk factors should receive appropriate counseling regarding recurrence risk and the importance of urgent evaluation if acute pelvic pain develops. With timely diagnosis and appropriate surgical management, many women with ovarian torsion can preserve their affected ovary and maintain normal reproductive capacity. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.